Okay. So can you hear me or see me?
I can see you, and I
Okay,
see
great.
a retrorectal multicystic lesion
Yes.
touching the coccyx, I think. But
And
so
cancer?
I'm thinking about like retrorectal hamartoma, epidermoid, tail gut cyst. And one
Where's my
last week that
T2?
was
Sorry, I had my T2. Here's my T2 axial.
Rupa showed one last week
Oh,
that
sorry. Sorry,
turned
that's
out
not
to
T2.
be endocervicosis, which was weird.
Oh, okay. Well, my
Wait, so this one has like T1 bright areas, so like epidermoid.
wait. Hold on. I want you to focus on the GYN parts.
Oh, yeah. There's also like indistinct T2 gray mass of the cervix.
Yeah. The rectal stuff.
Ignore.
Yeah. But let's look at
Unrelated.
the rectal stuff. I don't, it's not enhancing.
I mean, it's in
Okay.
that retrorectal hamartoma differential. It's fine. You can talk about the cervix. It
Okay. All right. Well, this patient has
looks like
cervical
cervical
cancer.
cancer with like parametrial spread.
Yes, that's exactly right. Exactly right. Where's my T2? Oh gosh, I had my T2. Yes. So my what I wanted to discuss was post-treatment complications. So yes, so she has parametrial invasion, and so she subsequently underwent radiation therapy, and this, complications are real, and this is what happened after radiation treatment.
Oh boy. Oh Jesus. Sorry.
So like the bladder wall has disintegrated and there's a fistula between the vagina and the bladder.
Yep, exactly. And so it was and it's a large fistula, and so she got diverted. So she underwent a loop colostomy and a ileoconduit just to divert the urine and stool, and so her fistulas are healing.
Wait, go back. Was there also a fistula with the rectum?
There's,
or it's just like socked in there and they decided to just divert
I
it?
think this is like inflammatory changes. I don't really know, but this has been stable for us a few years. Oh, I see what you're saying. Yes, there is a fistula to the rectum, probably. We don't have a pelvic MR, but I suspect there is, like right here, maybe right there, because there's like, tethering and stuff, and I feel like I can almost see a fistula here. And then definitely a fistula to the bladder, like we saw. So this is just a complication of radiation treatment, and for us to be wary, to look out for these things. I mean, in this case, it was, obviously very significant complication, but yeah.
Question, Nelly, do you know what kind of radiation they did? Like a tandem and ovoid or like external beam? Seems like probably external beam.
I don't remember seeing a tandem, like, because we usually do I don't
Displacement
yeah,
imaging.
yeah, exactly. We usually do but we didn't have that done here. I'll find it and see if I can get that information for you.
Okay,
So
just
it's probably
curious
external
because it
beam.
looks like I've seen a lot of cervical cancer shrink away with radiation and like not necessarily have all this complication, so seems like it was like a little bit, maybe it was more extensive because the tumor was more extensive, but
Oh, I remember radiation was not done here. It was done elsewhere, so I don't know how they did it.
This was a patient who was referred to us from outside institution. This was a study. The patient patient has prostate cancer, and then incidentally somewhere was found to have pancreatic ductal dilatation. And this was in the MR that we got. We have no prior, imaging, and you can see that there's asymmetric dilatation of the duct, right? And there's something here, right? And if we look on T2, there's a little more convincing, right? You can see that the distal duct is atrophic. The distal
Cut off.
atrophic, there's ductal, right? So you know, I read it as, you know, probably tumor, right? Suspect tumor at this level. I also did think that there was like a little bit of kind of enhanced, like, you know, thing here.
Yeah, like contour deformity, like it looks almost like
So-
atrophic in that area.
Do you guys agree that this is kind of a reasonable read, right?
Yeah, I would say at least an EUS, because chronic pancreatitis and stricture can cause this, but 50% turn out to be cancer. I
Right.
think in this one paper that was published in Abdominal Radiology.
So they decided to do CT
Ooh,
first. And this is really interesting because this is a total mimicker, total like fake out on MR, right? Because we can't see the calculus really. That's the, you know,
Victoria, I have this exact same case, and like mine was the same thing where duct cut off, couldn't see the stone, and then the CT totally helped. So
right.
I don't know, what's the takeaway? Interrupted duct without a definite mass. Do you also recommend a CT?
I guess, I mean, you know, this is, I think of all the you know, of all the cases that I have like this that ended up being cancer, I think this is the first one where there's nothing like, because the rest of the pancreas looks so beautiful. Look at that. It's not like he has, she, I don't know, prostate cancer. It's not like there's other, like the rest of the pancreas has anything, like the rest of the pancreas looks completely normal. So there's nothing here to think, oh, maybe this is just, you know, a stone there. So
Okay, I
do you
a
have
really
the
dumb
T2
question.
coronal?
huh?
Do you have the T2 coronal?
Okay, okay, let me, can you, here's Nelly, here's the coronal, right? So it kind of looks,
Yeah,
again,
hard.
just this, and here's the MRCP again, very, and the thing is like, if you look carefully, right, there's nothing on the MRCP suggesting that there's stones. But on CT, there were plenty of stones. So I really have no good explanation of why it was.
You know, I have this theory.
Yeah.
I need to look this up, but you know how we do MRI for CBD stones? Like the MRI is way better than CT for CBD stones,
Yeah.
right? But then pancreatic stones and calcifications, it sucks at.
Yes.
So my theory is that the CBD stones are like, you know, either cholesterol or pigmented stones. They're not really like calcified stones. And so we see them better on MR, but then the actual pancreatic stones are totally different composition and calcified, and that's why we see them on CT.
But you would think that, you know, the feeling, they would form feeling defects and really nothing here. So it was, you know, it was
If
interesting.
you're showing them RCP, we're not seeing it.
Right. This is MRCP and really like.
Wait, I can't see it.
We just see the T2 coronal.
Oh, I'm sorry. I forget that Monty here. I'm sorry. Here's the MRCP. I forget that. Never mind. Here's the proximal duct. Looks pretty good. And then the distal
Oh
duct
yeah,
is kind of
it's hard.
regular, right? And there's really
Yeah.
nothing here,
Nope.
right? Because remember, for the, you know, for the for CT, it was like full of stones. So I really have no good explanation of.
I've totally been tricked by this before. And in my pancreatitis lecture, I actually have like, oh, and CT can be complementary. I have that like case where, but then on the other hand, I don't necessarily recommend a CT for every time I have an interrupted duct. So it's a good reminder.
Right. All right. So my next.
Hey. This is a patient with symptomatic fibroids. It's not an eye test. And I think this is a really, there's several, I think, great for me, great observation. So initially I looked at this, I'm like, oh, it's a subserosal fibroid. And there's like parasitic vessels from the, you know, right ovary here supplying it. And so then I looked at the prior, and then this is what it looked like. I'm like, oh, wait, it's not a subserosal fibroid. This was a prior from an outside facility, and the pelvis is not in the field of view. So this
is
is
stalk, like
yeah,
right there. There's
yeah,
a stalk, right? Like it's a
yes,
pedunculated fibroid.
right there, yeah, yeah, exactly. And so if we go back to the this study, bring the axial, you can see that stalk. It's right here. It's a vascular stalk. and it's separate. You can see it's separate from the uterus, which is here posteriorly. The other interesting observation is, the gynecologist wanted to look for malignant degeneration. And, when I look at the T2, it to me looks totally benign, but, of course, there's areas that are T2 hyperintense. I don't have the path yet, but there are like hyperintensity, right? Which I think are just fibrostroma, right? Like here, for example, centrally. And along the lateral edge, and on post contrast, there is, areas of degeneration and non-enhancement. But even in the areas that are enhancing, there's T2 hyperintense signal. So if we follow that consensus statement that Nicole authored, and you go down that pathway, it actually leads you to suggest sarcoma.
Wait, I have something to say here.
Yes, say.
So first of all, fibroids can undergo cystic degeneration.
Agree.
So if the majority, or even like, parts of it are dark like this, I think to me, that's a fibroid with cystic degeneration. And leiomyosarcomas do not arise from fibroids. So the idea of having malignant degeneration within something that otherwise looks like a fibroid is not, for the vast, vast majority, how leiomyosarcomas even arise. So if the most of it looks like a fibroid and one part of it looks degenerated, then that's degeneration of a fibroid. It's not like, oh, there could be a leiomyosarcoma in that one spot.
Yeah, no, I'm not saying that it's a degeneration of a fibroid into a LMS.
Well, you started it off saying she asked us to look for malignant degeneration, but like that.
Oh, sorry. Yeah, sorry, go ahead. Yeah.
You're saying that she asked you to see, like, is this malignancy, not
yes,
degeneration?
Right. It'll change their operative approach. So like this is not degenerating. Look at this on the right. So the T2 hyperintense signal is not in the areas that are degenerating. And I don't know, like if the rest of it looks like all of this T2 dark stuff look like fibroid, but not all of it, right? So I don't think just because the majority of it looks.
Kind of my point is, like, when on pathology, my pathologists have told me you don't see leiomyosarcomas in fibroids, like they're not admixed. You could have them both in the same uterus, like a fibroid in one part and a leiomyosarcoma in the other part, but they're not in the same lesion because they don't arise from fibroids.
Okay, so I hear what you're saying. It's either a fibroid or not. It's a sarcoma or not. So my question is, if you have areas that are heterogeneous like this, what pathway would you go down?
I'm actually pulling up Nicole's
because in
thing,
some of the examples,
I think if it's mostly T2 dark, you don't even use that algorithm.
Let's look it up, because I don't know. I don't know if this mostly is enough. Like, for example, this, like, the transmural, this is obviously a classic benign leiomyoma, right? This is what my understanding is based on the consensus statement saying. If it looks like this, T2 hypo, then this is done. You're done. But this, and the pedunculated one doesn't look like that. I mean, I still think it's benign, but that pathway is leading me down the sarcoma path, and it creates a conundrum because now our gynecologists are kind of tied.
Okay, put them side by side, the T2 and the post contrast. I pulled up her algorithm.
Okay.
And it says the T2 of the solid enhancing tissue, if it's intermediate to high signal, that you go down the pathway, but if it's not, then it's benign. And I would argue here that the majority of the enhancing stuff here is T2 dark. I'm putting my money on fibroid here.
No, the question is, if majority is T2 dark, can we just say it's benign? Because here, the areas that are enhancing are not T2 dark.
Okay, well, we're gonna ask them.
Yeah, and I agree with you. Like, to me, I look at this, and yes, it looks like a weird fibroid, but it still looks benign to me. And like I said, what threw me off was when I was going down the pathway, I'm like, oh wait, actually, but I can't just definitively call it because there are areas that are enhancing that are T2 hetero, and they are hyper intense on the high B value relative to endometrium. And it restricts below 900 on ADC. And I was just a little bit disappointed because I wanted to say, oh, it's a fibroid and be done with. And with that pathway, it kind of threw me into a different, area space. Path pending.
Okay. Can't wait for the path. And I will ask Nicole. Okay, Victoria, do you want to go?
Okay, so this is my miss. I want to share with you. Okay, so this patient had prior resection, and this is the most recent CT. Now, I did not read that one. I read the one before. And, you can see that here the finding is very obvious, right? You see that the, arising from the resection margin onward, you can see that there's enhancing tissue in right portal vein. And, it's clearly there's tumor in vein, right? So this is not an eye test. I just wanna, hold on. Okay, so then I read the one before, so I looked at the one before, and
I'm sorry, Victoria,
obviously
what did you say what the primary was again?
it was HCC. It was resected.
Okay.
It resected a few years ago. It was moderately differentiated HCC. So obviously, when something like this happened, like I always go back and see like what did I miss. So first, I looked here on the axial, and I don't know, it doesn't look terribly abnormal. So I was almost
I
like,
think like in retrospect, you see that hyper enhancing stuff, right? You're talking about the top right image.
so here's the arterial phase, here's the delayed, right? Sort of, but I mean, there's a mixture. I mean, no, obviously with a retroscope, it's easy. The issue, let me just, again, I'm sorry, I have to do this before I can show you. Okay, this is the one before me, right? So this is the CT done one before the case that I read. And I just want to bring up the portal vein. You see that they're like part of the banner. Those I can't take away. So hold on a second. I'm trying to find for some reason, hold on. Put on pause again, please. This is the case that I've read, yeah. And this is the one before it. So, actually you can't see that this, whatever this kind of site heterogeneity, right? It was not there before. So that could have tipped me off. Unfortunately, it didn't. And there
Sorry,
was,
I don't see what you're trying to show. I mean, the new
This-
what? Oh, I see it. Yeah. Oh,
slight,
super
very
subtle.
slight heterogeneity, very subtle.
Yeah.
Which I
But the
didn't
contrast timing is totally not like ideal.
right. And here's the but if you compare 1 to 1, it didn't look like that, right? But there was one image where you can actually probably prospectively there you can see on corona you can
That
actually,
early tumor thrombus.
yeah.
Yeah.
So you can actually see, it would have been a great pickup. Unfortunately, it
I
wasn't.
feel like the arterial phase on your study was also like suggestive. I'm just saying in retrospect. But
Well, actually,
I feel like that's even more than this one, the arterial phase on the axial. I felt like there was a lot of enhancement
that
right there.
yeah. Well, I if I bring up the arterial phase from the one before, I'm gonna try. August. Hold on. It's sort of similar, right? It's this is tough. This is I can't, like even knowing it's hard, right? Like there's some admixture there. So I think arterial phase is not as helpful, but I do think that sadly I didn't do a great job with this one. So
Better with that.
yeah,
We have the flow voids and stuff like that to help.
right.
Steve, you're saying we do better with MR.
Yes.
Yeah. I feel like maybe even like on diffusion, it might have stood out, but yeah, this
Right.
is a super tricky one.
Right. So, but so yeah. So that was my not a great story.
So this was a young male. And you can see that the liver looks heterogeneous. And there is this perfusion abnormality along the periphery of it. I will tell you, I don't have the answer for what's going on in the liver, but I've seen this a lot actually with young women who are on OCPs. And my theory is that they have like subclinical pileosis or maybe even SOS related to OCPs. But anyway, this was a young male who was having right upper quadrant pain. And then this was the finding I wanted to show you, which is the left adrenal gland looks like expanded and non-enhancing. So it looks like it's infarcted. And then I'll show you the MRI. Here it is on the MRI. So it's T2 bright. It is T1 bright. Post contrast, not really enhancing. And then this is the subtraction. So it was a little T1 bright, it's not enhancing. So we basically thought that this was a hemorrhagic infarction of the adrenal gland. And then the liver again is heterogeneous. Victoria, I was thinking about you with this case because I was like wishing that we had done EOVIST to see if like maybe in the SOS spectrum you might have been abnormality on the EOVIST on the hepatobiliary phase, but we had not done EOVIST. But the interesting thing is this patient has a history of lupus and antiphospholipid syndrome. And so I was looking this up. My colleague Amir showed me this case, but there's actually a lot of case reports of adrenal hemorrhage and adrenal insufficiency related to antiphospholipid syndrome. And so I just wanted to kind of talk about this entity for a minute. So antiphospholipid syndrome is a hypercoagulable state. It can be associated with lupus or without lupus. And I'm just going to go down to the discussion, but basically it's characterized by thrombosis of both the arterial and venous vasculature. So you're getting like DVTs and PEs, but you're also getting arterial thrombosis. And when it affects the adrenal glands, if it can often be bilateral, in which case it leads to adrenal insufficiency, which can be really morbid and catastrophic. There are multiple theories on why that is, but one of the theories is that there's thrombosis of the adrenal vein because the adrenal glands have a rich arterial supply, but they're only drained by a single adrenal vein. I have a very similar case where we had hemorrhagic infarction of the adrenal in a pregnant patient, and I found out that the hypercoagulable state in pregnancy can also thrombose this adrenal vein. So just something to think about and look for. And then another theory is that also the cells of the zona fasciculata, so part of the adrenal gland actually have receptors that are targeted by the antiphospholipid antibodies. So kind of like a direct antibody attack on the adrenal gland can also lead to lysosomal proteinases and then also microthrombosis. So there's a few different theories, but there's actually a lot of case reports showing bilateral adrenal gland hemorrhage and or infarction in patients with antiphospholipid syndrome. So just something to think about. If it's bilateral, that's when you're at this increased risk for adrenal insufficiency. Adrenal insufficiency, it can be very non-specific, like you can get weakness, lethargy, but also bilateral flank pain, hypotension, and they should undergo an adrenal workup. And I think this is where radiology is important here. So if you see, we're used to seeing a lot of adrenal adenoma is very common, but if you see something that looks more like an infarction or a hemorrhage, look for an underlying hypercoagulable state. And if it's bilateral, this actually could be really catastrophic for them. So make sure you bring that up for them to do the hypercoagulable workup. Any questions? See something in the chat.
Everything in this is SOS.
Well, this patient has antiphospholipid syndrome.
But like,
I do not think this was SOS in the classic form of like oxaliplatin or
right.
transplant. But I do think there's some kind of probably microscopic thrombosis going on in the liver, which I thought would be interesting to see on the so probably not SOS, but maybe some kind of other microthrombosis. And then I think the adrenal gland is probably related to
Right.
antiphospholipid adrenal hemorrhage.
Or like I guess not classic SOS, but like these microscopic thromboses, making the picture either, either like distal butt chiari on, on the level of sinusoid, because that portal venous phase really looked like butt chiari.
Here, this one?
Yeah.
Yeah. Like not the butt chiari of like hepatic veins or IVC,
Right,
but like at the SOS level. Yeah.
Right,
This
at the
sinusoidal level, I
sinusoidal
think they're,
level.
it's
Right,
gotta be, I think, related to
right. I agree.
microthrombosis in some way, but we have no proof.
Do the antiphospholipid folks get like a microangiopathy or something?
Yeah. So they get like basically thrombosis of small arteries and veins.
And veins, right?
Yeah.
Okay.
Yeah. So it's actually interesting because they can be both thrombophilic and thrombocytopenic. So like they can bleed and thrombose. And so it gets really, really tricky. This is where you need room on board. And if their adrenal glands are both out, then like you need endocrine workup too. So okay.
This is a re-review of sort of variant Müllerian duct anomaly that we can see.
Oh, cute.
So this one is if we look at the intercornea line between the two cornua, this indentation, there is a little bit of a mild indentation, but it's not that much, just mild. And what we see is there is a separation of septa that extends through the endometrial canal and through the cervix, right here, right there, probably, right there. So just a nice re-review of Müllerian anomalies. This is a septate uterus, and there's, just as a reminder, there's different subtypes. So this is a paper from, or the article webpage from Radiopedia. You can have a partial septum that goes into the endometrial canal, but not the cervix. Our case, it extends into the cervical os. So this is a complete septate. And then in some instances, the septum can go into the vagina as well. And so you can have both a septate uterus and a septate vagina. And the other differential consideration is bicornuate. So here's a radiographics article that shows with bicornuate that the distance between the intercornuate line, it goes below that line. And so we see that with bicornuate, and we don't see that with septate. So the distance is above that line. And so you can either have a convex, flat, or a mildly indented contour, but it should never go below the intercornuate line.
Nelly, so your septum, what did you decide? So you decided it was a septate uterus with a complete septum through the cervix?
I think it's complete.
Okay.
Let me reshare. I see a septum that's going through the cervical os. Where's my?
I think they can be
So I think it's a complete septate.
fibrous or muscular too, and yours looks like it had a little bit of both.
I agree. Yeah, this looks muscular.
Yeah.
And then the fibrous component is probably in the lower uterus, extending into the cervical os.
But the fundal contour is relatively preserved. It's not indented enough to be anything but septate.
Correct. Or to be of cornuate, bicornuate.
Right.
Okay. Victoria, do you want to go?
Sure. It's not an eye test. You can see like this perirenal tissue, right? And you can see that, low level of enhancement. You can see that similar tissue extends along the adrenals. There were some peribiliary, kind of funky peribiliary findings in the liver, little lymphadenopathy, and patient also had a PET very close to each other. And you can see that there's some little bit of metabolic activity in this finding.
lymphoma.
So lymphoma is one thing.
And do they have any myelofibrosis of their bones or bony findings, like to suggest either extramedullary hematopoiesis or Erdheim-Chester? It doesn't look like there's other findings of IgG4 disease.
No, so that was you got the diagnosis, not the, it's Erdheim. I can never pronounce it correctly. It's a histiocytosis. So this is the hairy kidney appearance, which I think is probably the best hairy kidney appearance I've seen in my life. So it was just a cute finding.
Nice. Nelly actually presented one a few weeks ago at Erdheim-Chester, and she reviewed the MSK findings. And I think there's like stuff in the long bones, but also did this patient have anything in their bones?
Well, not on the MAR. Let me see. I'm looking in the JAK and I'm not seeing anything in terms of x-rays. I'm looking at the PET report and the bones were diffuse marrow uptake, probably reactive.
I have a question. How do people get the definitive diagnosis of Erdheim-Chester? Like, did they biopsy this perirenal stuff, or is there some other way?
Good question. Let's see. I think so. We are, Sloan is different, right? Because a lot of times patients already come in with biopsy. So I don't see a biopsy in our jacket. It's possible that it says patient with, so initial study that we have says patient with histiocytosis, initial staging. So it must have been biopsied somehow.
You're working at Memorial now?
I am.
Oh, wow. We'll be, alumni together.
Can't keep track of this girl.
You relax. Okay. I literally, this is my third institution in my entire life.
It's just rapid in the past few years. I
Yes,
can
but I'm
get
not
myself to like Target, never mind another institution.
Are you actually in Manhattan, or are you doing outlying?
Physically in Manhattan, and we're not recording, right?
This is a patient with history of PSC. And here's the T2. Diffusion was not helpful because patient had a cholecystectomy clip, and so there was artifact from the cholecystectomy clip. Here is a 2.5 minute. So this was a really great call. And what was called was this finding here, this T2 intermediate lesion with kind of hypoenhancement. And this turned out to be cholangio. And what I didn't know is that you can actually, well, first, in patients with PSC and cholangio, I'm going to share my screen. Patients at Mayo, there's like a Mayo protocol for these patients, and it consists of the following. So there's patients, they come in, there's imaging criteria for them to become transplant candidate. The lesion has to be at least or less than 3 centimeters, and there has to be no extrahepatic disease. And if they've satisfied that criteria, then they can be evaluated for liver transplant. Vascular encasement of the hilar vessel does not preclude them from transplant. So that in itself is fine. And then if they do meet the criteria, then they get radiation. They get radiation followed by chemotherapy. And then they get a laparoscopic abdominal staging to make sure there's no peritoneal disease. And if we do all of this and the patients do well, then they can get transplant, which is very cool. The other thing that I didn't know that we can do is this patient actually underwent radioembolization. Let me show you. radioembolization of that area. And so I didn't know that we can do radioembolization for cholangio. And so I found this paper. It's relatively new, but there was a paper that, patients underwent radioembolization plus chemo for intrahepatic cholangio, and the outcomes was pretty good. So I don't think it's part of practice yet, but that is a treatment option for patients with cholangio.
Nelly, I had to take a phone call, but I missed the first paper you showed. I have two questions about it. You said Mayo Clinic protocol for cholangiocarcinoma for transplant. I have two questions.
For PSC.
Huh? For
PSC.
Oh, okay. So I've been, I was under the understanding that you can also do it for a Klatskin tumor, and this is an intrahepatic cholangio. Does it make a difference if it's intrahepatic cholangio versus Klatskin is one question I have. And I've also been told for that protocol, they have to be less than 3 centimeters. Is that something that is in that article or that you mentioned? I don't remember.
Yes, so it does. I want to share that article again. 1 second. Can you see my screen?
Yes.
Okay, great. So yes, that is one of the imaging criteria. Is it has to be under 3 centimeters and without extrahepatic disease. And so let me see. Intrahepatic is best treated with liver resection. Transplant for intrahepatic is fraught with rapid metastasis and has been abandoned in most centers. So let me see. So the short answer is I need to look it up to see if transplant is both like hilar, Klatskin tumors, and for intrahepatic.
It looks like in the abstract, they're mostly talking about unresectable hilar or CCA. Huh.
I'll follow up. We can do the next case and I'll let you know.
Okay. Because I had thought that protocol was for hilar, but it sounds like they're also doing it for intrahepatic. And also, I didn't know it was just for PSC patients. I thought it was also for patients who have just like a bad hilar that's like short, small, less than 3 centimeters, but just happens to be in a bad location.
So it says the protocol involves patients with early stage cholangio, or which is either unresectable or arising in the setting of underlying PSC.
Okay, so either one. So not just PSC patients.
We most commonly do it for PSC, and we do transplant for non-PSC cholangio. I found out we've done a handful, a few, and they've had good outcomes, but most of these patients don't have, they're not prioritized because they don't get exception points.
So
they never get
the same thing, and most of those are hilars. And the whole point is like, it's a small tumor, so it's less than 3 centimeters, but it's in a bad location. So then they get put on that protocol. Like if you had an intrahepatic cholangio that was less than 3 centimeters, unless it's central, most of those could actually be resected.
And you're right. Actually, I'm reading this and it says the protocol specifically excludes patients with intrahepatic cholangio or gallbladder involvement.
Okay. So your patient wouldn't meet the criteria then.
Yeah, wasn't that intrahepatic?
It was intrahepatic, and I had 2 cases. One was this, and I was looking this up. The patient hadn't had transplant yet. They just went Y90 for cholangio, and I didn't know what the results showed for patients who had Y90 for cholangio, and it sounds like it's a emerging thing, treatment option for patients with intrahepatic cholangio. So based on this paper, the patient would not be a candidate for transplant because this should be resected because it's intrahepatic. I had a second patient that I had as a companion case that did have hilar disease and did undergo transplant. So the teaching points were off.
Sorry to introduce confusion.
No,
It
no,
was,
it's actually very good because it, you know, it's during times of these confusion that clarity emerge.
Okay, so my understanding is in select centers, in hilar cholangios can be potential transplant candidates if they're less than 3 centimeters, no extrahepatic disease, they go on a chemo-RADS protocol, and then 6 months later, if they haven't progressed, they're potential transplant candidates.
Correct.
Okay, cool. Okay, I have a case. Okay, so this patient has a lot of cardiac stuff going on. They've got some lung stuff. We're scrolling through the abdomen. They have a hemorrhage, retroperitoneal hemorrhage here. We were doing a CTA to look for active bleed. We did not see an active bleed. This was a great pickup on my fellow Krishna. Tell me if you see
Something in the
anything.
aorta.
Yeah, is there
Yeah.
these like a dissection or something in there?
Okay, so I'm going to put it on bone windows. What does this look
Do
like?
you have the coronal?
Yeah.
Is that something embolic that's retained there?
Something what?
Like from
It looks like an Amplatz
Yes.
plug.
There were 2 Amplatz plugs in the aorta. So why would you ever put an Amplatz or plug in the aorta? Victoria actually already said it. So these have embolized from somewhere else. And
From the atrium?
yeah,
Oh, the heart was so massive.
okay,
And it
so
just
turns
migrated.
out, okay, so actually, if I can convince you, there's some motion here, but there's another Amplatzer plug right here next to a mitral valve here. Okay, so this patient
Wow.
had a mitral valve that was placed many years ago, and then had something called PVL, perivalvular leak. So basically the valve has moved away from the edge and there's a leak. So, some of the blood is going this way and then some of it's going backwards through the leak. And one of the things they can do to treat it is put Amplatzer plugs here to block off the leak. And in this case, they put 3 Amplatzer plugs in for this PVL, perivalvular leak, and 2 of them embolized down into the aorta. And
Okay.
actually, I think they embolized further into the femoral artery. And I just want to show you,
Retrieved?
huh?
Did they need to be retrieved after you detected it?
Yes, unfortunately, in this particular case, the patient had a lot going on and didn't make it, so they weren't retrieved at that point. But I'm just going to show you. Okay, so this is kind of a schematic of, so first of all, this is like an Amplatzer, and they had different sizes. They put 2 14s and a 16 for this paravalvular leak. And this is the valve, and then that's the leak, and then they put the little Amplatzer next to it. So, I mean, you can imagine if you put 3 Amplatzers here and it's just like they're trying to hold it on to something, how it could potentially embolize. But it was a pretty severe leak. In this case, there was like 75% leaking backwards. So it was a really interesting case. Any questions?
But that was incidental for you guys because the patient was probably like an ICU patient that couldn't say, "Hey, I'm having ischemic lower extremity."
Exactly. And actually, at this point where it was down here, below that, the vessels are normal. Like, so at this point, it wasn't actually symptomatic. Oh, you know what? Wait, what is this? Those are clips down there, I think. At this point, it wasn't symptomatic, but I read in the chart that like they said it had embolized to the femoral arteries. So I'm assuming later there was some ischemia. At that point, they weren't even doing imaging; they were in the ICU. But yeah, my fellow really picked up that there was some abnormal artifact happening in this aorta here, and then went into the history and found out that they that day had these Amplatzer plugs placed.
But they didn't stay in place very long.
No. Yeah, very complex case. I'm sure it was difficult for cardiology as well.
So we didn't used to have someone who did this type of work, but now we do. So I saw this one left on the list because nobody else wanted to read it. It's pre-surgical evaluation of a penile prosthesis implant, penile implant, and the patient is complaining of pain with use and thought it might be dislodged or something. And so you know, I'm not really experienced at this. So when you're not really experienced at something, you got to make sure you're right by by consulting the experts. Fortunately, there was a recent radiographics article on this that went through all the different things to look for. This is a three component system. So it's got the cylinders, which are the corporal bodies. Then it's got a reservoir up here, and then it's got a pump device that's
Can you double click on that just to make it bigger?
the back of the scrotum here. That there's this pump device. Then you can see it. Here's the pump device. Here's the two cylinders, and then this smaller field of view, the reservoir is out of the field. But when you go through the things that you should look for, which is this radiographics article, fairly recent, from Brazil, I think it was. Can I zoom in on this? I don't know. Maybe I can. Yeah. So identify the type. It's a 3-part type, and then assess the components. I looked at all the components. They all looked to be intact. Then it said evaluate signs of component displacement or migration. That looked okay. You're supposed to check to see if the tunica albuginea is intact, which it looked intact, and we'll look at that in a minute. Cylinder integrity, they didn't look fractured. There was no fluid collections. Oversized or undersized, and we can get to that. Then signs of leak, fluid, etc., and then signs of infection, which is kind of the same. We didn't do this with contrast. There's no clinical suspicion for infection, but this shape of the cylinders is abnormal, and this is one of the things that you could see, which is called buckling. So if the cylinders buckle into an S shape like this, it sort of goes one way and then it goes the other way and then it comes back again.
It looks twisted.
Yeah, they're both sort of buckling like this, and so
Like,
that S-shaped buckling is considered typical for like an oversized implant. And
Oh, that's so interesting. Wait,
Yeah.
did you guys have them do it with inflation and then deflation?
we did not. I don't know.
Because that's part of our penile prosthesis protocol. Is like,
Not described. I think this was not necessarily inflated because the reservoir looked pretty full, and these looked like, you know, not completely straightened out. They looked like they were a little bit flaccid, but even when they're collapsed, they shouldn't have this S-shaped configuration. According to the article, you can diagnose this with or without, and they've got examples. Maybe I can reduce this just a little bit. They've got examples in here of this buckling, which is basically this S-shaped buckling is considered abnormal. See how they don't have them inflated here, and they said it can be diagnosed even on images obtained with the cylinders in a deflated state.
oh,
So they're going to revise this, and hopefully it'll be right afterwards. But that was my conclusion on this one, is that this buckling is probably having something to do with the pain or dysfunction that the guy's having with the implant.
and just about Nelly also asked the same question: is it done in the erect or flaccid position? I'm curious if, in general, on this, in this radiographics paper, if they recommend doing both or it doesn't matter.
Yeah, I didn't read that part. So there would be a section here on technique.
Yeah, I'm looking at it. Yeah. Okay, it says multi-phase body surface coil placed over the penile region to maximize signal to noise ratio. All components of the prosthesis should be included. Ideally, MRI should be performed in both the flaccid and inflated states.
Yeah. So I don't think we did it in both, because we're kind of new to this. Like I said, we didn't have a guy who did this work before, and I think this is the only maybe the first or maybe the second I've even seen of this type of pre-surgical evaluation.
Yeah. If you do decide to do a penile prosthesis protocol, like specifically for that,
I
it
would
would be
change
good
it
to have
so that
both.
it would be doing it both ways. Yeah.
Just so you feel more confident, because otherwise you're like, oh, is it just floppy? Because like, what, you know, like,
Right.
cool, thank you.
All right. You're welcome.